Hi, everybody. Welcome back to Health Law Simplified. Hi, Elizabeth. Hi, Charles.
Hey, Sandy.
So great to see you.
You too.
Hi, Sandy. Thanks for having me.
Absolutely. For our listeners, we have Charles Baker from ATTAC Consulting with us here today. Charles is a distinguished leader in the healthcare industry, known for his strategic expertise in health plan compliance, our favorite, and operational excellence. And it's that operations piece that we're hoping to get the benefit of your expertise on today. Charles is currently Vice President of Compliance Solutions at ATTAC Consulting, a firm that works with health plans and managed care organizations. I was looking at your bio and I saw that before you were at ATTAC, you were the Director of Health Plan Performance and a Medicare Compliance Officer at a health plan that achieved a 5-star rating during your tenure, a big accomplishment. And I know that you have deep connections to the community in Michigan, which, I am partial to. I have to say, I was first introduced to you at a conference shortly after University of Michigan won the national championship, and you peppered your whole presentation with references to this fact, which I, perhaps alone, really enjoyed. So thank you for being here, Charles. We're super excited to talk to you.
Yeah, thank you for having me. It was a very exciting time to be a Michigan Wolverine.
Yes, we have our trying times and our exciting times. So I was hoping, I know I gave a little bit of your bio, but this is a niche industry that we're in. So if there's anything about your background that you wanted to add, we're really always interested in hearing how people come to this area of work, health plan compliance, government programs like Medicare Advantage and things like that.
Yeah, great. Thanks again for having me, Sandy and Elizabeth. Great to see you both again. We spent a lot of time on the conference circuit together, so it's nice when we can get together outside of that. So thank you for having me today. Yeah, I like to lovingly say that I'm a recovering social worker by background. Right, I spent the first 10 years of my career being a clinical social worker on an inpatient psych unit, and so within that environment, it really gave me a lens into how healthcare really operates and that synergy between the health system, the health insurance company, and then the community at large as well. So my administration track really kind of blossomed from there, and that I saw that there was real challenges on being able to meet the needs of clients when they would leave the hospital, right? And what are those systems of care within the community to help support those patients? And so that really got my interest in administration. And so I went down that track and kind of backed my way into this idea of being a Medicare compliance officer and being in the health industry space. I worked on the provider side in administrative capacities, and so I have a long experience within provider operations and in the health system as well. But once I got into the health plan side, I really saw the value that health plans could offer members by helping to coordinate that care. One of the things that I frequently say is that the health insurance and managed care organizations have the greatest opportunity to impact a member's healthcare journey because they're the ones that hold all of the data, right? They're the ones that tie everything together between the primary care physician and the specialist and the community organizations and resources that are available. And so from a population health lens, the health insurance and managed care organizations have kind of like the best driver's seat to support members within our communities. And so that's kind of how I got into this. Former professor at the University of Detroit Mercy in population health and epidemiology through the nursing program. So this idea of population health is just really kind of what's driven me and how I kind of support health plans today from a compliance and regulatory lens.
That's a really interesting background, and I love how your experience gives you such a focus on the patient, the person that we're all here to serve in this industry.
Yeah.
So what do you do at ATTAC? I know you're in compliance. I do know, we've had a lot of chats about the many rule changes in Medicare Advantage, and I know that part of your job is to help plans implement those rules, but I'd love to just hear, like, what's your day-to-day like? What are some of the projects that you work on at ATTAC?
Yeah. So my title is Vice President of Compliance Solutions, and that's a little bit of a misnomer because I touch a lot of different aspects of the managed care industry, really focusing on those government-oriented healthcare products. So your qualified health plans, your Medicare Advantage plans, your Medicaid plans. And, right now, my interest is really into the D-SNP products, right? So as we see the SNP products continue to grow throughout our industry, that's kind of what I have fallen in love with, and it's what's really piqued my interest as of late. But again, that title's a little bit of a misnomer because what I really do on a day-to-day basis is look at the contractual and regulatory requirements, whether or not that's your state administrative contract that you hold with the state as a Medicaid managed care organization, or the regulatory requirements set forth by CMS from a Medicare Advantage perspective. I try to break those down into plain English for health plans and understand how to operationalize them and use those regulations and use those as guiding principles on how to operationalize and operate your health plan, right? A lot of this, as you know, because you sit in the regulatory space with me quite frequently, there's a lot of nebulousness around these regulations, right? There are some black, there are some white, but there's a lot of gray space in the middle there. And that's kind of my job, is to kind of help organizations understand that gray space and how to utilize it for the betterment of their population and for their business as well.
Charles, we are really focused, as are a lot of our clients and friends right now, on risk adjustment and risk adjustment data validation, or RADV audits. And as we've talked about, CMS has announced and is starting this massive expansion of RADV audits. We talked in our last episode about some of the nuts and bolts, like the number of claims, the scope of the audits in quantitative terms, but sort of more holistically, based on what you're seeing and hearing, how is this generation of RADV audits different than what we've seen before?
Yeah, so like I kind of led into, right, there's that gray space and that kind of nebulous nature of what's happening right now. We're all kind of drinking from the fire hose because this is very, very new for us. In previous years, CMS would do really targeted based audits, and a limited number of health plans were being selected on an annual basis. And this year, starting for 2019, if you operate or hold an age contract, expect to be getting a RADV audit. So CMS has really ramped up the oversight. And I think it's because it's one of the remaining bipartisan things that congressional leaders can agree on right now, right? Protecting the Medicare Trust Fund and really understanding this idea of overpayments for managed care organizations to maintain the Medicare Trust Fund. And honestly, I think that's something that we should be doing, right? Making sure that the dollars that are allocated to our seniors are going to the right place for the right reason, and that those dollars are being used for the betterment of a member's health care to make sure that their needs are being met, right? So right now, what we're seeing within the industry, again, is this new widespread approach touching all health plans, and that is creating an immense operational burden, right? CMS is coming in with a new targeting methodology, targeting 35 members for those conditions that they expect, what is it they said, predicted to have the greatest reduction in their risk score as a result of a RADV audit, right? And so instead of kind of being this random sampling approach, CMS has now moved into this very targeted risk-based approach.
Yeah. What is your view on, how this is likely to impact Medicare Advantage plans financially, operationally, or, all of the above?
Yeah, I mean, I think the financial ramifications are yet to be seen, but this is really where we're going to see extrapolation occur. So they're going to take these 35 member results and extrapolate it across an entire population of your membership, the results of that, right? And so that could be a very huge financial burden from an overpayment perspective. And I expect there to be lawsuits, and I expect this to be a long road to sow, right? I don't know that we're going to have the final results of the audit results anytime within the near future based on pending lawsuits that are likely to occur. But what I can say is that managed care organizations right now are faced with a huge operational lift that is going to be financially impactful to them as an organization. For each of these 35 members, they're looking at anywhere between 160 and 200 charts per member to validate those HCCs, right? And so just being able to pull those charts, to do some proactive oversight, to get some insight into what those charts are looking at like and what's going to be validated on the front end prior to submission is really important, but it's a very huge uplift and financially burdensome for organizations.
What do you think plans should be doing now to get ready for audits?
Well, I mean, I think one of the things that I advocate most for is taking a really holistic look at your risk adjustment program from the ground up. I mean, really take a philosophical view of your risk adjustment program and say, how are we using risk adjustment for the betterment of our member population, and what are we doing with those diagnoses once we have them, right? It's one thing to have those HCC codes for the purposes of reimbursement. It's another thing to incorporate those HCCs into quality initiatives and then really target them for quality improvement, STARS purposes, and just the overall betterment of health for members, right? So starting at the philosophical approach, looking at your organization's strategy. In preparation for the audit specifically, I think plans really need to start ramping up their internal teams to be able to pull these charts or start working with a vendor very quickly to be able to onboard and operate and orient a vendor to be able to help them support that. So whether or not that's, doing the chart chasing and making sure that you have all of the charts on hand and have a process for that, or doing some mock validation, right? So looking at the OIG's risk of HCCs and then kind of targeting some of those charts to do some internal monitoring and auditing of those charts. And then looking at your risk assessment process for your organization, your ERM program, to make sure that there is a heavy emphasis on the risk adjustment program, and that's included within your monitoring and auditing process.
Can you just, in case anybody isn't familiar with it, what the acronym ERM, what are you referring to there?
Yeah, Enterprise Risk Management.
Gotcha.
Yeah, so enterprise risk management. So usually it's a function within larger organizations. It's a standalone department, right? I always encourage your enterprise risk management to be incorporated within your compliance risk assessment as well, because those two things should be tied hand in hand. You don't want to look at it from just a financial perspective. You really want to tie in a lot of those regulatory requirements as well as a part of that ERM process.
Especially with the nature of MA, we've been preaching that for decades, actually. You can't think of compliance as this other thing because it's tied in through star ratings and otherwise, and really does affect your bottom line directly. So when you are assisting a health plan with an audit, sort of when do you get involved?
Yeah, so I mean, we are, so we're involved at all aspects of the audit, right? So before the audit has been, you've received your notice, right? We'll come in and we'll help you set up some audited monitoring process on the front end. We'll look at your risk assessment process. We'll make sure that you are reviewing 3% of all of your encounter data submitted to CMS. We'll kind of help set up that process, right? So what does that audit and monitoring process look like? And how do you report that up to leadership and the board of directors? We'll look at the delete process. The delete process is more important now than ever, right? And so if you aren't able to validate those encounters and those HCCs prior to submission, you need to have a really robust delete process involved there. Kind of once the organization has been selected for the audit, we'll sit alongside them, right? We'll operate as a chart retrieval vendor. We have internal coding that we'll do as well. And so once CMS has given a managed care organization their member target list, we'll go in and we'll help develop those chart chase lists. And we'll help organizations get optics into what the charts are looking like, and then help them identify which two charts have the best substantiating evidence for those HCCs. Now, post-audit, I mean, we haven't gotten there quite yet, right? But previously, when organizations have gone through RADVs. We'll help on the back end, right? We'll look at some of those findings. We'll look at the process, and we'll help them set up, again, kind of from a strategic perspective on how are they interfacing with their provider network. Right? What is the education that they're providing to their providers to ensure that the documentation that they have does meet muster with CMS, right?
Yeah.
So like, are the charts coded appropriately? Is there substantiating documentation? If you're doing HRA assessment, is there a subsequent encounter for those HCCs with a primary or specialist visit? Things of that nature.
Yeah, and I have a question about the providers, because we were talking yesterday with a colleague who works with large provider organizations that accept risk. And one complaint that they are increasingly having is that the deletes are getting, like, maybe there's an overcorrection. And so they're submitting valid codes, but they happen to align with the OIG's list of suspect codes, and they're getting just summarily deleted, and that's hurting their bottom line because they are taking care of those complex patients. So do you have any thoughts on that? Like, is that pendulum swinging? Of course, it's hard to get it just right.
Yeah. Well, I mean, I don't think CMS is going to go through this process and find codes that you missed, right? So they're not going to pay you back during their process for the codes that you may have missed during this RADV audit. It's all those that you failed to document. This is one thing that I talk about a lot. I mean, the onus is really turning back to the providers and the documentation standards that provider organizations have. So a great deal of provider education to make sure that the providers that are in all organizations, not even just those that are risk-bearing, but all organizations, are documenting in such a way that they can substantiate the codes that they're submitting to managed care organizations for reimbursement. And then really looking at the contractual arrangements between the managed care organization and the provider health system. You know, when I was sitting in the seat of a managed care organization, shockingly, but not so unshockingly, some of those provider contracts haven't been dusted off in a number of years.
Yeah, no.
Right?
And don't have all the things you need in them if you're doing risk-based in this environment. Yeah, absolutely.
Yeah, and so that's really where you want to develop that relationship with the provider network management team of the managed care organizations and talk about this from a strategic perspective. Is the managed care organization giving you insight and the data that you need to be a really high performing organization? If the managed care organization doesn't have the ability to be sophisticated in the data that they're giving back to you for, prospective coding, right? So that year over year prospective persistency rating, year over year. If you're not getting that information and everything's new to you and what you're supposed to be capturing, you could take a hit there. If the HCCs that you're documenting don't have lab work and specialist visits and all these other things that would traditionally be associated with that HCC, that's an area of opportunity where the health plan and the provider organization can come together to develop training. To talk about this as a holistic approach and how we're making sure that those codes don't get deleted. Right? I mean, everybody wants providers to be paid for helping populations. That's the entire purpose of this program.
Right. I mean, these contracts, a lot of them were developed. It was, the first time they'd done anything like this. And so they didn't know what the issues were going to be. So we are seeing, I think people are so overwhelmed right now. The idea of like updating and amending and restating contracts is just kind of, too much to think about. But yeah, once people can take a breath, a lot of those really do need some updates thoughtfully done with lawyers that understand the environment and the issues. Oh yeah, totally agree. Coming out of these, I mean, this is sort of a crystal ball question, but do you anticipate challenges to the audit findings?
Yes. 100%. I mean, I'm surprised that you haven't seen more of them already. I mean, if you look at the news cycle, anytime anything happens within the risk adjustment space, the major industry organizations and the largest health plans in the country kind of join together to start legislation and challenge the methodology for CMS, whether or not it's the targeting methodology or the extrapolation methodology. And so that's kind of the caveat that I led into earlier in the segment, is that I don't know how quickly we are going to see CMS collect any of this, right? Because I think as soon as it gets released or the first large organization gets a result from this audit that says you owe us $1 billion, do you think that the large healthcare organizations that we have in this country aren't going to sue? Of course they're going to sue.
Right. Yeah. No, and I think, for smaller ones, it could put people out of business. So.
Yeah, I mean, think about your nonprofit provider-sponsored health plans, right? I mean, a lot of those have traditionally relied on very skinny profit margins on the health plan side for reinvestment in technology needs. And so if they get a 7 or 8 figure fine, I mean, that's 5 to 10 years worth of margin for them.
Mm-hmm.
Yeah, these are really valuable insights. We've been concerned about that financial impact for plans that have just been accustomed to carrying the risk under the program in a different way and on different timelines. This is a really dramatic change in how oversight of risk adjustment has been done. And I'm right there with you. I'm waiting for those lawsuits to drop any day now. And I have to just add for our listeners who can't see us, Elizabeth and I have been nodding along to everything you've been saying, Charles, especially when you talk about looking at risk adjustment from the ground up, right? Looking at the philosophy of your risk adjustment program, revisiting those contracts. I know that's very challenging in this environment when companies have so much to do and are really, drinking from a fire hose of new requirements. But, it's not just about getting through the next RADV audit. It's about mitigating risk of a False Claims Act lawsuit, not ending up on, in the headlines of a Wall Street Journal article, et cetera. So just really appreciate the holistic view that you're bringing to this issue. And on that note, one struggle that we have in this industry is, we've talked about how coding accuracy is really critical to plan performance. If you're overcoding, you've got legal liability, you've got these, repayment obligations to CMS. If you're undercoding, you don't have resources to treat members. But at the same time, really common practices have come under scrutiny, right? Things like retrospective chart review, chart chases, provider queries. I think in an ideal world, you want the plan and the provider to be communicating really proactively about, what conditions does a member have and how are they being treated. But, this is something that's been called out in, a number of lawsuits as a red flag. I know that some physicians feel like there's pressure, from the health plan to add diagnoses that weren't really treated. So just given this really high pressure enforcement environment and all of the scrutiny, do you have any insights from your time as a compliance officer as to what MA plans can do to design a risk adjustment program that sort of balances those compliance and those performance obligations?
Yeah, I mean, think about the inception of the risk adjustment program and when we started to move in this quality payment direction 10 years ago, right? 10, 15 years ago now. We really wanted to move the needle, right? The congressional leadership and population health experts really came out and said, we in America need to do healthcare differently. We spend the most per capita out of any nation on the planet, and our outcomes aren't substantially different than other parts of the world, right? And why is that? And how can we do better? Well, we can do better by incentivizing providers and health plans to take better care of and be more proactive in the care for members. And so how are we going to do that? Well, we're going to incent them financially, whether or not it's quality bonus payments or risk adjustment methodology. We're going to now reimburse you to really take care of the sicker population so that we can employ population health initiatives that will hopefully drive members to the right point of care, right? Allow for proactive treatment of chronic conditions before they become burdensome and financially burdensome to both the member and the provider and the managed care organization themselves. And so that was really kind of the way that in which all of this came to be. right? We want to take that and give you dollars for taking care of the sickest people in your population. Well, how are we going to do that? Well, we're going to identify who those people are. We're going to identify what their chronic conditions are. We're going to look at what their HCCs are, and we're going to pay you more to take care of those things. And so what I had always advocated, and I worked very closely with our risk adjustment team using kind of this philosophical orientation, and I said, what are we as a health plan doing with this information? Right? I mean, it's a very simple question. We do an in-home health risk assessment. We do an in-home HRA assessment. We have found out that Betty Jo Bielowski has congestive heart failure. What are we now going to do with that information? And so if there isn't a feedback loop to take that information and now enroll Betty Jo Bielowski into some sort of population health initiative and communicate with Betty's primary care physician, and we're not going to now manage that congestive heart failure, then why are we doing this, right? If we're only doing a risk adjustment program for the purposes of financial reimbursement, we're going out and we're chasing codes, we're going out and we're chasing charts to be able to upcode based on things that we saw retroactively, then is that really meeting the kind of what the program was designed to do? And so really I always start there. That's the building block, right? And then you go up from there. So like when you're looking at those provider-based contracts and when you're looking at partnering between the managed care organization and the provider, there needs to be, in those full risk contracts, there needs to be some give and take, right? So if Betty Jo has congestive heart failure, provider, I'm telling you that they have this, and we're going to need you to manage them better based on the dollars that you have associated with that, right? Whether or not that's increased monitoring, looking at the medications, how are you going to now manage Betty's care better? And so then this is where compliance and risk adjustment can interface, right? So compliance. What is your oversight of the risk adjustment program? Like, are you seeing those codes being passed over to the providers? Are you making sure that the HCCs that are being reported back from the providers, are they being substantiated through the medical documentation and coding for some risk mitigation purposes, right? So you really want to limit your exposure and adhere to the philosophical nature of the program as a whole.
Yeah, totally agree. Totally agree. Do you have any thoughts? So CMS has emphasized it's going to be using a lot of new technology to facilitate these, not just a lot more staff, which it is augmenting, but a lot of new technology, presumably AI. Do you know much about that, or what that's like, how, if at all, it's yielding different results or different experience for the plans being audited this go round?
Yeah, I mean, CMS has really kept a tight lid on their methodology, their targeting methodology, how they're applying their criteria, and what they're looking at. The thing that is really funny to me, and we talk about AI and we talk about the use of AI within these things, for Medicare Advantage plans, and you've seen this through the program audits this year specifically, CMS is really targeting the use of AI, right? Yeah. And AI making decisions.
Right.
And so then to turn around and say, oh, we're going to use AI to augment a lot of our capabilities. I mean, come on, right? Like, yeah. I understand that we want to be accurate and specific and, sophisticated in our data methodology and the way in which we do this. But like, what's good for the goose is good for the gander, right? And so if it's good enough for you to use, then we should be able to use it as well.
Yeah. Yeah. No, it's an interesting dynamic. But my sense is it would be very hard for them to do the work on their end for the volume of audits that they're proposing to do if they were not relying on AI.
I mean, it's impressive, right? I mean, the initial announcement came out to say that they were going to hire 2,000 coders.
Yeah.
Where are these coders coming from?
I don't know. I don't know.
Right? I mean, we have an internal coding shop right now, and we're actively looking for coders, and we're looking, organizations are struggling to find coding professionals that have the level of knowledge and expertise around the Medicare program to be able to look at these charts and really do an accurate and good job. And so where is CMS coming from them? I read an article the other day that was like, that talked about this, like, with these new RADV assessments and the pressure on retrospective coding, what will it do for the coding industry in India, right? Because a lot of those coding shops right now are offshore.
Oh, that's interesting. Yeah.
Right. And so if you then look at, if we're not using those offshore resources, what happens to that industry as a whole? I mean, think of India, Indonesia, some of those other offshore countries that have literally built billion-dollar industries on employing offshore coding resources. I mean, it's not offshore to them, obviously, but, employing those populations as coders, what impact is it going to have on them? Is CMS now using offshore resources?
Yeah, good question. Good question.
I don't know. I mean,
I don't know
there's
either.
always been a hesitation.
I'm curious now.
Right.
Yeah.
From a high tech and a high trust perspective, we've always been encouraged to keep your data on shore, right?
Yeah.
It's the safest way to do it.
Preferable, not required. Although some Medicaid plans flat out prohibit offshore. We did we searched 35 states for a client, and a number of them blankly prohibit it. But yeah, Medicare doesn't. So
yeah, and so where are those coders coming from, and what does it do for that entire retrospective and even the prospective coding industry at large? I mean, the reason why many organizations go offshore for the resources is you can get the same value, and they have the resources.
Mm-hmm.
We're not going offshore because we have coders sitting around doing nothing. We have a coding shortage here, and it is cheaper to do it offshore.
That would be an interesting FOIA request to find out. Are you using offshore coders? Tell us about it.
That's interesting.
Yeah.
Now I'm interested.
I don't think we'd hear back very quickly based on my personal experience, but.
Correct. I don't think so either.
Yeah. So interesting. Kind of switching gears a little bit. We wanted to talk about proposed legislation about MA billing practices, if you're game.
Yeah.
So, what can you tell us about the No UPCODE Act?
Yeah, so the No UPCODE Act, it was a bill proposed back in March. A Republican led the way and had a Democrat legislator sign on as well. It was first read aloud in committee and is now kind of circling through the congressional halls, right? And I think you have a number of industry experts and other committee members kind of looking at what the No UPCODE Act would look like. And so the No UPCODE Act is really trying to ensure that the codes being submitted for risk adjustment purposes meet the philosophical nature of the program, right? So no use of HCCs from an HRA assessment at all. The way that the bill sits right now is it specifically calls out no in-home HRA assessment coding whatsoever.
That's really interesting, Charles. Just sort of, so it's a Republican-sponsored bill that goes beyond the CMS regulations that have evolved over multiple administrations. So that's just an interesting tidbit.
It is. One of the things, something I say very frequently is that the one thing that Republicans do a really good job of in this space specifically is price transparency and financial fiduciary responsibility for the program. To protect the Medicare Trust Fund is the ultimate goal. And so there's a really high interest from the Republican legislature on doing those two things, right? Consumer protection and pricing transparency and protecting the Medicare Trust Fund for financial responsibility, right? Mm-hmm. And this kind of overlaps a lot of what the Democrat leadership wants as well. They want to hold big businesses accountable and make sure that the government isn't overpaying big business, right? And so if you see my LinkedIn post, I frequently say that risk adjustment is the only thing that's going to keep us from an all-on partisan stall fest because there is so much interest from both sides.
Yeah, for better or worse.
For better or worse.
So as somebody who's been following the politics on MA for a number of years, I've had to learn to tune out because there's so much that doesn't ever make it past the bill stage. But your comment on this particular issue and the bipartisan support are part of what has clued me into, the fact that we should be paying attention to this No UPCODE Act or, whatever form it takes. Do you anticipate changes to the ultimate legislation in terms of in-home HRAs and chart reviews, some of those specific practices, or do you think that's something the industry really needs to prepare to go away?
That is a tough question. I mean, I think there is enough lobbying happening from industry organizations that I would be hard pressed to say that HRAs are going to go away. So, like I was talking about the offshore coding industry and the impact that these audits would have on the offshore coding industry. What impact is this going to have on the in-home HRA business? I mean, there are several very large multi-million-dollar organizations that have been built specifically around these in-home HRA assessments, and so they're not going to go quietly into the night, right? I mean, this is their business, right? They're not just going to close up shop and go bankrupt. I mean, they're going to employ lobbyists and lawyers and bring everybody to the forefront.
Like like the sales brokers have, and successfully litigated. Now we know against a regulation that would have hurt their bottom line.
Right, and that's exactly right. I mean, there was just a ruling last week or earlier this week that the Texas court came down and said no. I mean, the $100 administrative cap that's out. Sorry,
no mas.
Do that.
Yeah,
right. And so I think you'll see something similar. And so I think what's happening right now behind closed doors and through those congressional hallways is that I think there's a lot of discussion around what those in-home HRA assessments look like. And unpopular opinion here, if we're an industry guy that's trying to help organizations make money and do well in the industry, but and if you're doing those in-home HRA assessments and getting those diagnoses and they just sit on a shelf, I don't think you should get paid for them. Point blank.
Yeah, no, if there's no more care, I mean, it's actually really not a good look. And we've been saying that for many years. Like, if somebody has a serious enough condition to be risk adjustable, they need to be getting care for that.
Right.
Yeah, and if they're not, that's really a problem.
Yeah, I mean, think about diabetes, right? I mean, it's as simple as a diabetic care. And so if you do these in-home HRA assessments, most, if not all, health plans have a very sophisticated diabetic management program within their organizations. And so if you do an in-home HRA assessment and it shows that this person's got diabetes and they aren't enrolled into your diabetic management program, then what was the in-home HRA assessment for?
Right. Unless they say, no, I don't want to, leave me alone. And you have that documented.
Right, but you tried, right? Like
you tried.
You put
Exactly.
forth the effort. You saw the communication that went from, hey, we captured this, we identified it. We're actually doing something about it.
Yeah, for sure.
And so kind of, if I'm reading the tea leaves a little bit, I think what ultimately will happen, if anything, is that what you'll see is the HRA diagnoses that are captured will only be valid if there's a subsequent claims encounter, right? So if that code is validated by a physician or a specialist or by additional testing and blood work or pharmacy-related claims, then I think that will remain in. But I think that this idea of just sitting it on the shelf, I don't think that that's going to fly anymore. So you asked earlier what health plans can do to prepare. I would have a really good persistency program that identifies these codes through your in-home health assessments and make sure that when you're running reports for those provider organizations, that these members and those diagnoses are on those lists.
Yeah. And maybe some of those folks, and I've seen plans address this, maybe they need somebody coming to their home. Maybe they're not getting to the doctor, in a traditional office setting, and they need that level of support.
I mean, and it is a great population health initiative. I had this dream a long time ago. I wanted to have ambulances. I wanted to get 100 ambulances, and we were going to start doing home visits again.
Yeah.
right? I mean, you think about the rural population, you think about the urban population that doesn't have access to transportation, to get places, to get their medications, to get their primary care visits. Like, okay, let's get back to doing house calls. And I think some other
Sure.
organizations have started to do that with buses and vans and all kinds of different stuff. But this is a great model for, again, population health. I mean, I sound like a population health person because I am. You can really have a huge benefit on members' lives by bringing the care to them.
Absolutely. So is there anything that you would like to see from Congress or CMS through regulation or policy going forward on risk adjustment programs and proper coding practices? You mentioned the HRA, needs a diagnosis captured in a home assessment needs to be validated by, something else within a reasonable amount of time. But anything else?
Yeah, I mean, I think the direction that I would like us all as an industry to go through is that this shouldn't just be a moral obligation, right? Like, you shouldn't just have the moral police to say these things out loud in a boardroom in which this opinion will be very unpopular, right? Mm-hmm. Through legislation, we need to have accountability back to the origins of the program, right? There's bad actors everywhere, but there's a lot of really good actors out there that are doing it for the right reason, that have programs that are specifically designed for quality and the treatment of members. And so really what I want to see is legislation match up with the original purpose of the program in order to create accountability for those that have chosen to make that an unpopular opinion in the boardroom.
Mm-hmm. Yeah, thank you for sharing that. That's a helpful perspective. And because I have worked in this managed care industry for so long, it's striking to me how different the public perception is from what I see a lot of times, including from, colleagues like yourself, that there really are people who care about a lot more than the bottom line. Although, of course, you have to make money to stay in business. But yeah, absolutely.
Yeah. I mean, the optics are terrible right now. I mean, it's sad. I mean, you get the one bad actor, and then it's applied across, all organizations, and even those organizations that have been called out as bad actors. People in that organization are still trying to do the right thing. I mean, we all got into healthcare for altruistic reasons.
Yeah.
I mean, I didn't become a social worker to say, I'm going to make millions of dollars helping people.
No.
That's a silly comment, right? Clearly. Yeah. I got into this because I want to have an impact on the world around me and have a positive impact on the healthcare our society needs.
Yeah. And that's pretty typical of, I would say, most of the people we interface with at health plans.
100%. Mm-hmm. We're all trying to do the right thing, right? And sometimes doing the right thing can be challenging when you're facing bottom lines and pressures from external sources. But by and large, 99.99% of the people that work in this industry are trying to do the right thing for the right reason, and that's to make sure that members get the health care that they deserve.
This is a little bit of a tangent, but it helped me when I started this law firm, I really grasped that mixed motives don't taint the whole thing. Like, of course, I want to make money because this is what I do and it's a business, but I also really care about my clients. And, so then that's sort of, I'm like, oh, maybe that's true of other companies,
Yes.
Even really big ones, it's
even really big ones.
We have this really binary, it's strange. Like, it contaminates your whole thing if one of your major motivations is to earn money.
Yeah, I mean, and I think that's kind of the world that we live in. We've moved into this either or.
No, it's
perspective.
Not helpful. No, not
and
helpful.
And it's not helpful, right? There's a both. There's a both and.
Absolutely. So we've talked a lot about risk adjustment, but that's not the only thing that Medicare Advantage plans have to think about or worry about right now. What are some other issues that you think the industry needs to be focused on?
Prior authorizations, right? Mm-hmm. Like let's think of utilization management and prior authorization. There was a consortium of health plans that recently agreed with CMS or signed on to start to reduce the burden of prior authorizations to their members and really put the healthcare decisions back into the provider's hands. I think this is really good. I think this is really good for the industry. I think it is good for us holistically, for health insurance companies to be kind of out of the clinical decision-making phase and empowering physicians to do the right thing. Now, the challenge with that is ensuring that we're managing care. We're managed care organizations, and we need to be managing the care. And really that means making sure that people are accessing care at the right time, at the right place, at the right service and whatnot. And so organizations are really going to have to double down on the interface between the provider and the managed care organization. And what that looks like can be any number of things, right? Full risk sharing agreements and other contractual agreements that providers and managed care organizations can come into. But it's really this interdisciplinary approach, right? That the health plan has really good visibility into holistically what the member is going through, while some of the providers may only have screenshots, right? Screenshots of different aspects of a member's care. How do you bring that all together? Right?
Yeah.
How do you now empower physicians to have that holistic look as well? Now, I talked earlier about the tools and offshore resourcing that CMS is potentially using. I'm not sure if they are. I mean, it's behind closed doors or not. But think about this WISER model, WISER. It is a new pilot program that CMS is initiating to explore using prior authorizations in fee-for-service.
I saw that, yeah. Yeah.
So now CMS is saying we can apply, we're going to test out applying prior authorizations in fee-for-service, but Medicare Advantage plans, we want you to start decreasing the amount of prior authorizations you have.
Yeah, right.
And so how do you marry those two things together, right? How do you now manage a member's care without utilization management techniques and prior authorization requirements?
And manage costs as well.
And manage cost and meet your margin. And, no margin, no mission. No mission, no margin, but no margin, no mission.
Yeah. Good point. Well, we like to conclude our podcast with some deep thoughts, deep questions. So looking back, what's something that you know now that you wish you knew when you started your career?
I'm gonna tell you a funny story. So I started my MHA program, and I was still a social worker. And I was this socialist. I was a social worker, die-hard, Medicare for all, universal health care. This is going to be great. That's kind of how I got into this. And so I walked into this MHA program, and my first professor on my first day was a very high-level member of a very prominent health insurance organization. He asked the question, how much money do you think that X company makes on an annual basis? And I raised my hand, and I said, tens of billions of dollars. Right? No. And we had this long discussion over, having margin, right? And what that looked like, and carrying 3 to 6% profit margin and how they reinvest that into organizations. And as I've learned throughout my career, working within provider organizations, working in the health insurance industry, it's like, wow, I was naive. Right?
Yeah.
Like I just didn't understand how. I lived in this world that was very altruistic and everybody is going to do the right thing because it's what they should be doing. And to be perfectly frank with you, that's not the way the world works.
No. And it's like an old Western where people are wearing black hats or white hats. And that is just not reality.
It is not. And so I think talking back to the 20-year-old Charlie Baker, I think I would tell him to be a little bit more open-minded around, how we influence the care of members and what does establishing sustainable systems of care in communities look like. And I honestly, truly, wholeheartedly believe that managed care organizations are in the driver's seat to creating these systems of care within communities.
Thank you so much, Charles, for joining us and sharing your insights. This has been fun and it's been informative, and I really appreciate your perspective.
Great. Thanks for having me. It's always good to get together with you guys.
If you enjoyed this episode, please subscribe wherever you get your podcasts. And if you want to find out more, go to strategichealthlaw.com. This podcast is for informational purposes only and should not be considered legal advice. If you need legal advice on any topic we've covered, please consult an attorney with appropriate experience in health law. Our music is Galaxy Love by Johnny Duke. Until next time, thank you for listening to Health Law Simplified.